had a history of more than 3 months. And 70% of those with T3, T4 tumors had an anamnesis history less than 3 months. And already there is an information about the tumor progression. So I think we are dealing with two types and two kinds of malignancies, really.
May I say something in follow-up to Jan? I completely agree that we have patients who don't hear well, who can't swallow well, who can't sit down to a holiday meal with their family. But partly it's because we have seen advances in survival as we intensify therapy, and we have not been able to identify who was going to do well with radiation alone, except for some crude staging parameters. And we haven't been able to understand who's going to do well with high-dose cisplatin, which we give to everybody, even though it's probably the case that if we looked at their DNA repair pathway, we would figure out who needs high-dose cisplatin and who doesn't. I think that with the activity that we clearly see with the 3-drug induction regimen, that there are going to be patients who perhaps might not need quite as aggressive local therapy. But I think that unless we do the painstaking work of looking at our entire patient population in every study and figuring out, okay, what defines a good response to induction therapy? Who really needs the 70 gray of radiotherapy? Who's actually benefiting from the 100 of cisplatin? Who's got, I don't think it's going to be a simple EGFR stain, but who's got activation of the EGFR pathway and is going to benefit from cetuximab? Then we'll pick 2 or 3 of these interventions at more tolerable doses and get the same or maybe even better results in terms of outcome, in terms of survival, without sacrificing swallowing in quite as many people.
Someone else who has any comments, questions? Bhuvanesh?
First off, I congratulate the panel on hitting all the important points, I think, that are pertinent to our field. I think what should be taken away is the excitement that the panel feels, and I think many of the audience members feel. I think this is a evolving field. Head and neck cancer is, as cancer is in general, with the introduction of new biologic techniques, the identification of stem cells as a potential of the progenitor of these tumors. But I don't think that we are anywhere near successful with any of the treatments that we have, whether it's platinum or radiation or surgery. And so the satisfaction is not there. The one point that must be taken away, if you look at survival data, and I'll use the American survival data, it's exactly the same overall survival for all comers with head and neck cancer today as it was in 1970, as it was in 1980, as it was in 1990, and as it is today. So we use PET, we use biologic therapy, we use better CT MRI, we have a better understanding of these tumors, and yet we have not achieved any improvements in survival with all of the modalities that we have applied to these cancers. So they're not easy cancers, and I think we should understand that as we treat these patients.
I think this is a very important point, and so older I am, so more I realize that survival is not everything. It is important the quality of life you have in the rest of your days. And I think this is maybe a very good message. Everything what we should do should help our patients to have for the rest of their days a good quality of life.
But still, survival is fairly important, Carl.
Yeah, but not only
one alternative.
There's no quality if you're gone.
if you stick all the day in a hospital or in a nursing home and so on, and look, again 1 month more, and so on.
For many of our patients, quality of life is very important.
Talking about perspectives,
Yeah.
I would be interested what the panelists think where we will be in 5 or 10 years from now concerning how to make decisions. Is it always the level of evidence that we have. From my German perspective, I have the feeling that from the chemo and radiotherapy, we have a lot of studies that have evidence levels that go up and up and up. And from the surgeons you hear, I do this kind of modification, I do that, and this is my personal experience. So in 10 years from now, I don't know if we will have so many new studies from surgery. So what will be the decision-making procedure in the future? And if it's the evidence level, where will the surgeons be in 10 years?
Can I come on at that? Because it was surgery and I'm responsible. The problem is, it would be a wonderful idea to do, as Wolfgang Steiner showed us, let's say CO2 laser surgery for a T3 or T4 laryngeal cancer, and then to wait and see when this gentleman will die, from which risk. But nobody can expect and wait. So we will start sometimes to give additional chemo to irradiate the patient and so on, because we treat patients and not animals. And this is the point why we have in surgery we have problems. Then the stage 2 or 3 of our multimodal concept, like chemotherapy and irradiation.
It's a very important question you are coming up with, and I forgot to say and have that on the list, because it's coming up when it comes to snoring operations, for example, and the treatment there. Because in surgery, we lack the evidence, and that is really hits back to ourselves. And I think we have to be more careful and put up prospective randomized studies in, for example, ENT in many fields, because it's coming more and more, and as you said, say that in the molecular, or in oncology with radiotherapy and with especially then in pharmacology, you have quite a lot of prospective randomized studies, but we have very few in surgery, very few, and it's a lack that we have to do something with, perhaps in multi-center studies, but it depends so much on the individual surgeon too. So it's not easy, but we have to look into this. Someone else? If not, I thank you for being here to 6 o'clock, and I thank the auditorium to stay. I thank the panelists for their active participation. Thank you very much.